the introduction of the core standards for acute trauma care in 2013. With more hospitals coming up in Singapore, not all the hospitals had equal capabilities, and we decided to do pre-hospital major trauma diversion in 2014. That means if you are in a region where you are not near a major trauma center, then you'll be sent to a major trauma center if your injuries are quite severe. We'll take a look at the map later and I can explain. And we had a national trauma unit that was established in 2017. The hospitals all got accredited to deliver trauma care based on the core standards. And we had 3 NTC subcommittees to focus on the key areas of our trauma system in the early 2020s. Okay, so this is a map of Singapore. As you can see, the trauma group is actually divided into 3 major groups. So we have the Western Regional Group, the Central Group, as well as the Southeastern Regional Group. But of course, this is actually just based on geographical location, and the population they serve is actually quite different. The central part is not that big, but it actually serves the bulk, at least about half of Singapore's population of 2.8 million. And the southeastern side is where I work in. We serve about 1.3 million population. And the west side is actually the largest cluster, but it serves only 1.5 million. So for instance, if you are in Fong General Hospital, which is one of the more peripheral hospitals, and you have a major accident, you actually may get sent to the bigger hospital in that cluster, which is the National University Hospital. So over there, they'll have services like cardiothoracic and neurosurgery, which are missing in Fong General Hospital. And KK Women's and Children's Hospital is right smack in the center of Singapore, and they serve all the children who require pediatric trauma support. So the national level Ministry of Health actually looks at the national trauma policies, and they actually own our trauma data. These 2 smaller committees, which is the National Trauma Committee and the National Trauma Unit, come under the Ministry of Health. And under the National Trauma Committee, there are 3 different subcommittees which look at different things like the outcomes and quality assurance, training and education, as well as emergent issues. So next, we'll have a look at the Omni system. We'll help you to appreciate the patient's journey from the time that I pick up onto the arrival in the hospital. So Omni is our new electronic system that has been used since 2-3 years ago. Before that, everyone was using pen and paper, but with this new system, it's all electronic. So can we have the video?
Hello, 995, what's the emergency? Yes, ma'am.
The person number is 995. Actually, assess the patient's record. I've learned before arriving. Ambulance crew is 3 people. Have the driver, the paramedic, and then EMT.
Sometimes I add traumatic feature and need to call the active traumatic, assemble all the team members, then let's prepare the result. The job will be in charge of every, so let's prepare the every step of the acute. Simply reduce circulation.
Okay. So this is his existing injuries. It has abdominal contusion and also active bleeding over the right lower limb. May you proceed with tranexamic acid infusion for this patient?
Hello, 995 was emergency.
This is the first version of the operating system. We are coming out with version 2, so hopefully there'll be some improvement. Alright, so I showed this earlier regarding the protocol for the major trauma. So I'll just move on. So there are special diversion criteria as well. Like for burns, more than 15% second degree, we'll send it to a specialized burn center. So that's the other one. And of course, if it's a pediatric, then they go to the pediatric center. So in terms of a trauma kit, this is some of the equipment that we have in our ambulances. So for instance, if there's a patient who needs to be extricated from a car or a vehicle, then they can make use of this green thing on the top right-hand corner, which is called the Kendrick's extrication device. So the paramedics will safely extricate the patient and from the vehicle and put into the ambulance. We also have things like box splints on the bottom left-hand corner to immobilize any fractures. And there is a teapot or pelvic splint, as you can see in the middle. And the bottom right-hand corner is a tourniquet that we've mentioned earlier. So this is a snapshot of what we actually see from the Omni system. So this is actually the paramedics' view, what they require to key in. So there's actually a diagram of a man, and they can actually indicate the injuries, they can draw on it. Then of course we also ask certain things like whether the patient has required extrication, whether there was any immobilization done, like head immobilization, cervical collar, backboard, pelvic binder, so on and so forth. And we also ask for some details of the road traffic accident, because all this information actually goes into our National Trauma Registry. So we need to know things like whether the patient was a driver or was he a passenger, and whether he was wearing a seatbelt, whether the airbag was deployed. So in Singapore, all these centers have a trauma team, and the trauma team composition is more or less the same. So far as I know, it's just a single tier system in Singapore, and we have a trauma team leader, which is either an ED physician or a trauma surgeon, and we have an ED doctor, ED nurse, general surgery resident, or orthopedics resident. So the role of a multidisciplinary team is really to assess the patient together and make sure that the decisions are done quickly so that the patient can receive the best care. So in a way, the way the things are run, it should be quite similar in the sense that the person who is taking care of the airway should stand at the head of the bed. And then to his left, maybe someone who is looking at the vital signs or setting an IV. And on the patient's right, it will usually be the trauma leader or a resident who will be doing assessment like a primary survey, doing ultrasound, like fast scan to see whether there's any free fluid in the abdomen. And the nurse usually will be recording some parameters and checking out the timings of interventions done. And of course, we have the radiographer who will come in and do the x-rays as necessary. And of course, we'll send the patient to the scan room to do a CT scan as soon as possible. So for trauma team activation, this is just a snapshot of our criteria in my hospital. So similarly, we divide into physiological, anatomical, and mechanism of injury. And like I mentioned, the purpose of a trauma team is actually for a multidisciplinary team approach so that things can be done quickly and everyone has a specific duty. Everyone needs to know what they have to do when they're there. And of course, sometimes there can be additional disciplines that we require. For instance, a patient who has a low GCS and maybe a blown pupil, we will probably have to call a neurosurgical team to come down. Patient with severe burns, we'll need to call in the plastics or the burns team. And patients who have maybe a traumatic aortic disruption, we will need to call in a cardiothoracic surgeon. So all these are additional ones that we will call in after the initial assessment and maybe the imaging has been done. And of course, with a team, we actually have more people on board that can help to resuscitate the patient. So we have more people who can help with setting of lines like trauma lines to give things like blood products, IVTXA. We also have more people who can help to do life-saving procedures like resuscitative thoracotomy, which is usually done by the ED consultant or with the general surgery registrar. Chest tubes insertions can be done by any residents. And also have to prioritize the imaging required, especially when we have 2 or more patients who come in and we only have 1 scan room. So we need to decide, whether which patient should go to the scan room first. And of course, we also need to come up with a management plan to see whether the patient needs to go to the OT or to the angio suite for angioembolization, to the ICU, or can the patient just go to a general ward and wait for further treatment subsequently. So investigations will always be done in the ED. This will be things like bedside ultrasound, which we usually do e-fast, and we also send outside laboratory to make sure the patient is not anemic, make sure the renal panel is fine. We also try the coagulation profile, group and cross-match, liver function test, amylase, lactate, as well as cardiac enzymes. For radiology, we'll start with basic ones in the emergency department. So for x-rays, we usually do a chest and pelvic x-ray. And CT, we can do a PAN scan, which is a brain, cervical spine, thorax, abdomen, pelvis. If need be, we can do angiography if, let's say, they have a pulseless limb. And if they have some kind of cervical spine issue or some kind of a spinal cord syndrome, then we can always ask for MRI subsequently. So we'll try to do our best in the emergency department through the principles I've mentioned previously of permissive hypotension as well as hemostatic resuscitation. And then subsequently we'll hand off to the surgeons to do damage control surgery. So as with everything, there's a need to actually have a continuous learning. So amongst the different centers, we all have learning opportunities with all these online training sessions. So the central region, they actually have online courses that they do every month. So this is an example. If you're interested, you can scan the QR code and then attend as well because it's over Zoom. And they'll be talking about 3 memorable cases for open abdomen. That's all I have for this presentation. Just a heads up, Singapore will have annual scientific meeting, which is the SAMS ASM in February 2025. This will be on the 27th and 28th of April of February. So if you're interested, more information will be provided in time to come. So just take note of the dates. Thank you.
Thank you very much, Dr. Iwan. So I would like to introduce next speaker, my colleagues from Thailand, Dr. Prinya Thiemviboon. He is an assistant professor from the Department of Emergency Medicine, Faculty of Medicine, Chiang Mai University, in northern part of Thailand. So he's gonna share us about the trauma care system of Thailand. Please welcome Dr. Prinya Thiemviboon.
Okay, hello everyone. I'm Dr. Prinya from Chiang Mai University. Today I have the topic that will share you about the trauma care system of Thailand. Maybe it has something that you can adjust to your system. Okay. First, I will start with the system of the Thailand. The trauma care system control the pre-hospital trauma care. If we have the accident just like this, and the people saw the accident, the victim, so the people will call the emergency medical number 1669. Because of in Thailand, we don't have the universal number for all emergency condition. If they want to contact with the police, call 191. If they want to call to the firefighter, they call 199. But if they want to contact the medical ambulance, 1669. Almost the patients can remember 1669. So it's very popular for anyone. Snake attack their home, call 1669. Or thief go inside the house, call 1669. If they call the 1669, the call will direct to the emergency dispatch center. Emergency dispatch center have the call taker. Call taker will collect the details of the injury or the event and send the detail to the emergency medical dispatcher. Emergency medical dispatcher will categorize the emergency and the severity and give the response code red, yellow, and green. After that, the assistant of emergency medical dispatcher that we call the coordinator will contact to the ambulance, the nearest ambulance, and send the ambulance to pick up the patient. And when the ambulance go to the scene, after the treatment, ambulance will bring the patient to the nearest hospital. If they have any problem, they can call to the emergency dispatch center. The medical director, who is the chief of the dispatch center, will give the medical direction, online medical direction. National Institute of Emergency Medicines, they set the levels of the EMS unit. At the present, we have the 3 levels. First is the first responder. The second is the basic life support unit, and the last is advanced life support unit. Almost the ambulance in the hospital, from the hospital, is advanced life support unit. And the first responder is a volunteer in any area. In Thailand, we have the first responder more than 5,000 units, and advanced life support is more than 1,000 units. And National Institute of Emergency Medicines, in the future, they try to change it to basic, advanced, and specialist units. The specialist is just like the example of specialist units in my hospital is the Sky Doctor, the team that go with the helicopter to pick up the patient. And in Bangkok, we have the specialist units, just like the stroke team or the toxicologist. And about the levels of EMS personnel, we have the EMR is the lowest competencies, and the EMTB, emergency medical team, emergency medical technician basic, and emergency medical technician, emergency technical intermediate, and advanced emergency medical technician and emergency medical technician paramedic. So we have the 6 level. Any level have the different competencies. To scope and responsibility and limitation of practical medical personnel, National Institute of Emergency Medicine sets the law and regulation and scope the level into 5 levels for the medical personnel. Level A means the procedure permits to be performed. And level B permits based on protocol. The medical personnel can perform this procedure if we have the offline protocol. And level C is permit based on the direct medical direction only. Maybe the team call to the emergency medical dispatcher and medical director give them the online protocol. They can perform this procedure. And level D permit only if the doctor stay or perform at the scene. Supervision of this procedure at the scene. And level E not permit for this procedure. The example of this procedure just like the adult orotracheal intubation. EMTP paramedic can perform if we write the offline protocol. Advanced EMT, EMTI can perform if the doctor stay at the scenes and supervision them to do. And EMT, EMTB, or EMR not permit to do that procedure. And we set the response time to treat the patient outside the hospital. Response time means the duration time from receive the call from caller to the ambulance team arrive at the scene. Depends on the code from the emergency medical dispatcher. If that patient was received the red code, the FR team, first responder, have a limit time to go to the scene within 4 minutes, and advanced life support team within 8 minutes. If the yellow code, first responder go to the scene within 8 minutes, and basic life support team go to the scene within 15 minutes. If the code green code, only first responder go to the scene, no time limit. But if the dispatcher give them the white code, not send any team, they have to go to hospital by themselves. Okay. The standard of care in the pre-hospital care, we use the pre-hospital trauma life support. The step is the X, A, B, C, D, E, as the slide, and limit the scene time within 10 minutes in the severe case. Because of some area in Thailand is the remote area, and some areas are wilderness. Just like in my region, I work in the region 1 in the north part of Thailand. Is mountain, so very far from the hospital. The patient have to bring the injury patient walk top of the mountain to the area to the hospital. So it's very hard to do that, and the outcome is worse. So we need the helicopter, we need the sky doctor, but the main problem is we don't have any money to buy the helicopter. So we contact to the military and the police and collaborate with the military and the police, set the MOU to use their helicopter and set the Northern Sky Doctor team. After that, National Institute of Emergency Medicine set the policy, one region, one Sky Doctor. So in Thailand, we have many teams of the Sky Doctor. The primary mission is bring the patient from the scene to the hospital. And the secondary mission is bring the patient from the primary hospital to the university hospital or tertiary hospital, because some primary hospital is very far from the university hospital. Just you see on the slides, some hospitals take time if they transport by ground ambulance, use more than 5 hours. So the outcome of the trauma patient is worse. So we use the Sky Doctor to inter-facility transport, hospital to hospital. We also have the medical boat ambulance in the southern part of Thailand by collaborate with the Navy and the private agency. The primary mission is bring the patient from the island or on the sea to the hospital. And secondary mission is inter-facility, the same as the Sky Doctor. And about the in-hospital trauma care system, the Royal College of Surgery of Thailand set the level of the trauma center into 4 levels. The level 1 is the comprehensive trauma care. This level has the training, is the training center for the general surgeon, trauma surgeon, and emergency physician, and have the research for improve the quality of the trauma care. This will have the 24-hour in-house covered by general surgeon, trauma surgeon, orthopedic, cardiovascular thoracic surgeons, or microsurgery. And this level receives the referral of the injured patient from level 2, 3, and 4 trauma center. The next is the level 2 trauma center. This level is the tertiary care or secondary care. They can cover all of the 24 hours of all injury, but they don't have some specific disease, just like cardiac surgery. They have to transfer the patient to the level 1 trauma center. And the level 3 is the provincial hospital. This level has the emergency medicine, general surgery, or orthopedic surgery. If they have the complex case, transfer them to higher level of trauma care. The last one is the level 4. This level don't have the surgeon. They have only the general practice doctor that train the ATLS course. The ATLS course is the standard of care in the emergency department in Thailand. The approach, the step of approach is the A, B, C, D, E. And we try to contact with the general practice doctor and send the general practice doctor in any hospital to train and certify this course. In university hospital, in my hospital is the Maharaj Nakhon Chiang Mai hospital, is the level 1 trauma center. We have the criteria to activate the trauma team, the same as the Singapore. But the trauma team in my hospital, the member is only the trauma surgeon. The trauma surgeon staff, the trauma surgeon fellow, and the trauma surgeon, the general surgeon resident, they contain about 5 to 6 members in the team. If we have the meet the criteria of full team activation, just like on the slides, you can contact them. But if you want some of the member to give your opinion or join to exam or reevaluate the patient, only partial team activation. The trauma team will go to the emergency department within 15 minutes. And we have the massive transfusion protocol for trauma because in the severe case, that estimate blood loss more than 30% of the total blood volume needs more than packed red cell. They need the coagulation factor, the platelet, to improve the outcome. So we set the criteria to activate massive transfusion protocol. By the physiologic is we found the hemothorax or bleeding in abdomen. And we estimate that blood loss more than 30% and have the physiologic criteria that one of the following heart rate more than 120, low blood pressure, serum pH less than 7.2. So we activate this protocol and give them the whole blood. Why whole blood? Last year, we give them the packed cell, FFP, plasma plasma, and platelet. But from the research, whole blood has better outcome than 3 components. So this year, we use the whole blood. And we set the fast track severe traumatic brain injury in emergency department. The goal of the this fast track is the patient visit to our emergency department to the ED exit within 60 minutes and transfer them to the operation room to start the incision for cranial surgery within 120 minutes. By set the criteria as on the slides, after we implement this protocol, the mortality rate in operation room was decreased just like this. So if you want to improve the outcome in the trauma case or severe traumatic brain injury, you may set the system or some fast track that you can perform or collaborate with any agency. Then the next is the video that I will summarize the system. Okay. 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 So you will see to develop the system, we have to collaborate with many agencies. So the effective system born from the good collaboration, and the great system will lead to the greater outcome. Okay, that's all of my presentation. Thank you very much.
Yeah, thank you very much for your presentation. Next topic, I would like to invite Dr. Saparia Faza Zamaluddin, visiting consultant, emergency physician, hospital, and Sun Abdullah.
For example, in Thailand and Singapore. Right, and I like to thank the organizing committee to allow me to share about the trauma care systems in Malaysia. Malaysia is a small country in that corner of the world, and we are quite close to each other, to Thailand, Vietnam, Laos, Indonesia. So the Southeast Asian country, we are pretty close together. Malaysia is divided into 2 parts. On the left of your screen, that's the Peninsula Malaysia, and on the right of your screen, that is the states of East Malaysia of Sabah and Sarawak, which is on the island of Borneo, and we share the island with in Indonesia. The Peninsula Malaysia is more part of Malaysia that's more developed compared to the eastern part of Malaysia. We have many things unique in our country. We have the most largest and the stinkiest flower. That's the Rafflesia, the big flower that you see there. We have the most delicious and stinkiest fruit, the durian. We have the national flower, hibiscus, and I think even Korea has hibiscus as the national flower. So we do shade the pink hibiscus for Korea, right? And we have the Malayan tiger, which is our national emblem, the orangutan. And we once had the tallest twin towers in the world. So, but we're still the tallest twin towers in the world, the Petronas twin towers. We have many ethnic people in our country. We have the Malays, like me, is the majority of the population, Chinese, Indians, and the Bumiputras, the origins of the country. Our total area is about 331,000 square kilometers. It's nearly as big as Vietnam. However, Vietnam's population is 3 times that of ours in Malaysia. 33 million in Malaysia compared to about 98 million, if not mistaken. 98 million population of Vietnam. Our capital city is Kuala Lumpur. That's our financial capital, and our administrative capital is at Putrajaya. We have 13 states and 1 federal territories. We have 160,000. We have 160 public hospitals, which caters for more than 47,000 beds. But there are more private hospitals, but less beds. So the public hospitals are free, a very, very minimal charge. It's about 20 US cents to a visit to emergency department, where you'll get all the investigations and drugs and treatment to be given, less than 20 cents. Our physician ratio in Malaysia is 1 to 2.2 per 1,000. If you compare with Vietnam of 0.2, Thailand of 0.9, and Singapore 2.4, and South Korea. So pretty low still in Malaysia, and of course in Vietnam. If you look at the cost of death in Malaysia, as any developing country, it's at the same thing as around this region. Ischemic heart disease is the primary cause of death. But the death through injury in Malaysia is our 5th most common cause of death. And if you look at the ages where they die, 19.2% of the patients who die from injuries are between the 15 to 40 years old. Again, as I said before in previous lecture, these are the time that they are in the reproductive age group. So unfortunately, these are the young people on the motorbikes or going on the roads, drive very fast, do not follow rules. And during this Eid festival time, a lot of people go back to their hometowns, and they do have a lot of accidents in Malaysia during this time. The same thing, I think, in the Lunar New Year, if you go back to your hometowns, a lot of accidents will occur. So injuries and from road traffic accidents are a major cause of trauma in our country. Again, it's talk about the cost of trauma. In the death per year, it's about more than 6,000. Now it comes back to 7,000, but I think it has stabilized about 7,000 plus since after the year 2020. But the cost of it has gone up, right? From 8.7 billion ringgit, that's about $2 billion US dollars, to 20.6 billion the cost. And WHO estimates, right, that it's about 24 billion, right? And it's 23.6 fatalities per 100 population. That's still very, very high as compared to the developed country. So we talk about the trauma system. So what I will discuss about the trauma system in Malaysia is to cover 3 areas. That it's not comprehensive in the time that I have. So what I will talk about in the little bit of the pre-hospital care, the hospital care, and of course the on the research and audit part. As for pre-hospital care, I think that's one of the things that our areas of interest here is to look into the pre-hospital system in Malaysia. And during the discussion that we had on our visit to the ER here, that is quite, it's pretty similar to the one that we have in Ho Chi Minh City. We have a universal number that started in 2007. Before that, we have 6 or 7 individual numbers. You want to call the hospital, you call direct to the hospital. You want the fire, you call 994. You want the police, don't know what number. You want to call hospital, you call 999. So in 2007, the government integrated everything, and they have a one universal number, one Malaysia, one number, that is the 999, right? So the 999 calls, if you need for any of the emergency services, the ambulances, the police, the fire and rescue, the civil defense, you call 999. That 999 calls goes to a telecom communication center. If you want to have the police, the telecoms will pass it to the police. If you want it, an ambulance for any medical condition, the telecoms, the 999 telecom center will direct you to the nearest Malaysian Emergency Coordinating Center, or we called it the MACC. There are many MACCs over in Malaysia. It is distributed through all the states in the Peninsular Malaysia, and over on the East Malaysia, over in Sabah and Sarawak. There are about 22 MACCs in the country to cover to cover the whole country. So let me go through the system or through the flow of what happens in case of an accident or injury. Generally, what happens mainly across the states of Malaysia. If there is an accident, they will call 999. From the 999 telecom center, they will divert the call to the nearest MACC. Let's say the call goes, there is an accident around in Kuala Lumpur, our capital. Will go to the nearest MCC in Kuala Lumpur, that is at Hospital Kuala Lumpur. The MCC are hospital based, so they're based at hospital. For example, for this case, accident in Kuala Lumpur, if it's nearest to the Hospital Kuala Lumpur, the call will be directed to Hospital Kuala Lumpur. From Hospital Kuala Lumpur, either Hospital Kuala Lumpur will send their ambulance to the scene, or will direct the nearest fire rescue or the civil defense or the St. John to the scene. Mainly the hospital or the hospital care in Malaysia are usually hospital based. It's run by the government service and it's based in government hospitals. The fire rescue, the Red Crescent, the St. John Ambulance Brigade, and civil just help to cover some of the areas. So other than the hospitals, the government health clinics also helps to response to our emergency call. So being at hospital, the hospital might not be in a good hotspot area, so it do take some time, right? Once the hospital responds, or the health clinic responds, right? The patient, if the patient is near to a trauma capable hospital, the patients will be sent to the trauma hospital. So it's and I heard about the 115, that if you call the 115, that caters about 25% to 30% of emergency call, the cases get sent to the nearest hospital. So the same thing occurring over in Malaysia. Once the ambulances brought the patient to the emergency department, they are all brought to the emergency department, whether they are specialist hospital or district hospitals, they are all sent to the ED to be resuscitation. In hospitals where the emergency physicians, the emergency physicians will be the main trauma team. There are not many hospitals that have trauma team activation system in their ED, even for big hospitals. So most of the EDs will practice a two-tier emergency, two-tier trauma team system, which means that the ED team will see the patient first. If they need, if they require, they will quickly call either the surgical, orthopedic, or neurosurgical team. There are a lot of hospitals in our country that is surgical capable, which means that they can do general surgery, they can do the trauma patients, but there are very few neurosurgical hospitals. So if this patient needs, if they arrive at your ED and the patients need to have a craniectomy, they will later be sent to neurosurgical capable hospitals. Once they are resuscitated at the ED, in which I found out now, a lot of hospitals do have the massive transfusion protocols, especially the big hospitals. And they do have giving transaminase acids, the same thing as what's happening in Singapore, what's happening in Thailand, the same process undergoes in the ED in Malaysia. From that, either the patient can go to ICU if they need ICU care, or go directly to the operating theater where the surgery is done, or they can be transferred off to another hospital or sent to the ward if the patient is stable. The patients need interventional radiology, or they need CT scans, they'll send to the radiology department. We don't have many interventional radiologists in our country. A lot of them has gone to the private hospitals, and as I said, the private hospitals are not part of our trauma system. So a lot of patients do end up, if they require, under the surgeon's knife. Once the patient recover, they are sent for rehabilitation. The rehabilitation team do see the patients a lot, quite early. We do have a national rehabilitation hospital in Kuala Lumpur, but our rehabilitation system or centers are far in between. I myself, I need a rehabilitation appointment. It takes me 1.5 months to get a rehabilitation appointment. So I think this is one area that we really need to look after. Right. So we have our pre-hospital care system, right, which are hospital-based. And then we send them to the nearest hospital. And that is really very an inefficient way to treat the trauma patients. So we are discussing about having a trauma bypass system, having an ambulance system that is put together rather than being hospital-based. So because we know this deficiency, around the Kuala Lumpur area, we have tried a pilot project called the Klang Valley Ambulance Service, or KVAS, that pulls all the ambulance in the Klang Valley, in the Kuala Lumpur area together. They run their own MCC, but the coordination is done by one center, right? So which means that now the ambulances are no longer hospital based. The ambulances can be put anywhere by the KVAS system. And then the paramedics, our paramedics that runs the ambulance system is different from the rest. Here you have the EMT-based system. For ours, we have like what we call the physician assistant. They are diploma, they're like nurses, right? But they can do things to assist the doctors and do other things by themselves. So before this, our paramedics divided between helping the pre-hospital care and helping in the emergency department. So today you can be working in the emergency department, tomorrow you can be working at the pre-hospital care. So it's not a very efficient way to share resources for pre-hospital care. So in the KVAS system, in the Klang Valley the service pilot project, they have given X number, quite a lot of paramedics now, just to run the hospital, the pre-hospital care service around in Kuala Lumpur. So they dedicated for that, and that's quite good because they are focused to do pre-hospital care. They are not attached to the hospital and get involved in hospital care. Right. So the ambulances can be placed outside the hospital now, right, where they they can be put in the hotspot areas that has been identified that MACC. They have one emergency physician who is a pre-hospital specialist, the EMS physician, who is on call to cover this Klang Valley ambulance service. So if they need any information, any treatment advice, it will be handled by this emergency physician. So let's go how the Klang Valley ambulance system works. If they're collecting data now, they're looking into some of the quality indicators. And if this works, then probably it will be expanded to other parts of the nation. So again, if there's an incident in the country or there's incident site, the 999 call will be called by the public into the telecom center. Again, the telecom center will transfer, divert the call to the nearest Malaysian Emergency Coordinating Center, the MACC, which is part of the Klang Valley Ambulance Service. Now, this Klang Valley Ambulance Service team, now they have the right to bypass the nearest hospital and send to the most appropriate hospital. For example, as I said, in Malaysia, we do not have many neurosurgical centers, right? So if this patient needs a the paramedic thinks that this patient needs a neurosurgical treatment, this patient will be diverted and trauma bypassed to the nearest operate center, for example, neurosurgical center. But to make that decision, they have to discuss with the emergency physician on call for that medical directions. Our paramedics also give IV tranexamic acid to the trauma patients, general trauma patients, and those patients with head injury. They've set up a couple of KPIs for that, and the response time is one of them, and giving tranexamic acid was also one of it. The pusher for having the Klang Valley Ambulance Service was when the auditors of the country audited the pre-hospital care service. 85% of the time we do not manage to reach the response time of the P1 cases, which is the severe cases, within 9 minutes as stipulated. So it's a very sad state. So at least they start to move to establish the Klang Valley Ambulance Service, which have more leeway, more access, more ambulances, and more paramedics. At the moment, the limiting factor for this Klang Valley Ambulance Service is the lack of ambulances. Our ambulances are sometimes very old. They go to many places. They are overworked, right? And they do break down. So when they do break down, it's very difficult to get replacements. The ambulances are something that is not very cheap. Okay. So that covers the pre-hospital, the hospital care, because the hospital care, I think, is no different from most of the hospital care that you've heard before. We do have a lot of training for our pre-hospital care team, either in trauma or in emergency care. And not only we have the trauma education for the EMS, but we also have the trauma care for the rest of the people in the hospital. We have a monthly online trauma series. We have a cadre workshop. We closely with the Pan-Asian Trauma Outcome Study and that became our registry to look into trauma cases over in Malaysia. In 1920, we developed our own Malaysian trauma registry that would look into the severe injuries that comes over to the emergency departments. This education and this registry become an integral part and a very, very important part of the whole having a trauma system in the country. We do not have designated trauma centers. We don't have a level 1, level 2, level 3. We just have what we know is the hospital capable to manage trauma, the hospital capable to do spine surgery, the hospital capable to do neurosurgery, neurosurgery. We know that network, so we send the patient to the appropriate areas. And then the trauma registry can look into the movement of the patient throughout the whole system. And with that, I'd like to announce some of the conferences that we have. We have our second Mission Trauma Conference. Please come over. That will be the 2nd to the 4th of October. We have a cadaveric workshop, right? That will be, which you can learn how to do emergent thoracotomy, trichotiotomy, and all the other invasive resuscitation. We have the Malaysian Trauma Acrobatic Conference, 4th to 6th June. We will invite Professor Shin over to Kuala Lumpur because we would like to sign an MOU between the Malaysian Trauma Registry and the PATOS CRN so that we can collaborate and share data together, because we have stopped sending data to PATOS, so we can now use the Malaysian Trauma Registry data for the PATOS. And then for the last conference that I'd like to talk about, we have our EMAS conference. It's not here, which is our emergency medicine conference. We will be on the 5th to 6th of June. So that's another conference that you all can, not very far away. It took me only 1.5 hours from Kuala Lumpur to Ho Chi Minh City. I'm sure Bangkok is close, Indonesia is close. Singapore is also closer, yeah, just across the border. Okay. But to put all these systems together, right? The pre-hospital injury prevention, pre-hospital, hospital care, rehabilitation, research, audit, registry. You need to have all the various stakeholders together, not only the emergency physicians. We might be the carer in Malaysia, carer of trauma care, right? But we need all the stakeholders, not only the various disciplines of surgery, radiology, ENT, ophthalmology, rehabilitation, but we also need the Ministry of Health to be involved, because the Ministry of Health hospitals are the one involved in managing trauma care. So they need to be involved in putting up a viable trauma care system in the country. And in this blueprint, we also mentioned to come up with the levels of trauma care in the hospital. We had this blueprint pre-COVID, but I think because of the COVID, this had been put aside, and I'm not quite sure when this Malaysian trauma care blueprint will be accepted by the Ministry of Health. Of course, there are many challenges for our trauma system in the countries. There are many challenges. I just divided into 3 areas. There's resource constraint and funding issues. Of course, money is always an option, and ambulance is not easy. Setting up a system probably will be probably a more efficient way of doing things, but you still need resources to pay for your paramedics, to pay for your equipments, and to pay for your ambulances. So therefore, if we focus on prevention, as mentioned earlier, prevention is always better than cure. It's so much cheaper to put an advertisement on television, to put an advertisement on the billboard for injury prevention, rather than to treat a patient with chest injury, head injury, pelvic injury, and that will take thousands and thousands of dollars. Integration of trauma care with a broader healthcare system, taking trauma as a disease, as I said before, be part of the whole trauma and public health system in our country, rather than this belongs to hospital, this belongs to private health. To break down the silos between the public health side and the hospital side, that has to be broken down. Of course, buy-in by the various stakeholders involved in efficient trauma care. Everybody needs to buy in. Everybody needs to believe that we should have an efficient trauma system in the country. Only then we can have a good trauma system in the country. With that, ladies and gentlemen, come on.
Thank you very much, Professor Sabarias. I would like to introduce next speaker from South Korea, and in the topic trauma care system of South Korea, Dr. Min Woo Kim. He is a doctor from Seoul National University Hospital. Please welcome Dr. Min Woo Kim.
Hello, everyone. This is Kim from Seoul National University Hospital in South Korea. And I'm emergency physician and now working on inter-hospital transport system in Seoul National University Hospital. Thank you for giving me opportunity to present in this symposium. So today I'm presenting the trauma care system of Korea, actually focusing on the program run in the capital city of Seoul, capital city of Korea, Seoul. So these are the key contents of the presentation. Pre-hospital assessments of trauma by EMS personnel in Korea, and Golden Time Hospital Program, which covers severe diseases in Seoul, and severe trauma final treatment centers, which cover the severe trauma patients, and Seoul Mobile ICU program for inter-hospital transfers. Before the start, I have to explain about the Korea. The area of the South Korea is about 100,000 square kilometers, and the population is about 50 million people living in South Korea. On the Korea incidence, incidence of mortality due to trauma is about 50.9 in 100,000 people, and it's much higher in the age of 40s and 50s. Okay. Sorry. So I'm gonna talk about the pre-hospital EMS system. In Korea, the EMS is run by a fire agency, and the type of EMS is similar as Anglo-American models. And EMS personnel are mostly consist of EMTs and usually provide basic supports for trauma patients. And there is 119 emergency procedure protocols for EMS personnel, which is regularly updated. And it contains the process of severe trauma recognition. It is almost same as the field trauma scheme in United States. Physiological signs, physical exam, mechanism of trauma, and patient factors will be considered to recognize the severe trauma in the field. And EMS always write down the EMS run sheet for every dispatch to record the information of the event. And in case of severe trauma, additionally, in-depth registry for severe trauma should be written. So you can see on the right side of the slide, this is the form of severe trauma. Oh, sorry. So this is the form of severe trauma in in-depth registry, and EMS personnel fill this form with tablet PC during the dispatch. And so the EMS personnel should fill the form which contains timeline of the dispatch. It's in the red box. This is the severity assessing part of the registry. As I mentioned, it contains physiological signs, physical exams, and mechanism of trauma and patient factors. And with these information, EMS personnel judge whether the patient has severe trauma or not, and write down the decision on the registry. And in this procedure protocol, there are chapters for trauma and injury, and they consist of several types of injuries, such as multiple trauma, altered mentality after trauma, head trauma, spine injury, thoracic injury, abdomen pelvic injury, genitourinary injury, limb injury, ophthalmologic injury, dental injury, and environmental emergencies. Each chapter contains a clinical feature of the trauma, particular assessments for the trauma nature, and emergency procedure protocols, and specific caution for the cases, and indication for direct medical direction. And finally, hospital selection of the patient. And the procedure protocol also contains procedures for the trauma patient. It contains immobilization and splint apply, bleeding control, and dressing for the patients. So actually, pre-hospital emergency procedure is quite simplified, and there is not much procedure performed in the field for the EMS. So now I'm gonna talking about the hospital selection. In Seoul, there is program named Golden Time Emergency Department program run by Seoul Metropolitan Government, which 26 hospitals in Seoul participate in. These hospitals are supposed to provide treatment on 4 types of severe diseases. They are cardiac arrest, cardiovascular disease, neurovascular disease, and severe trauma. So we recommend that EMS transfer severe patient to the nearest Golden Time ED as soon as possible, and severe trauma patients are also recommended to be transferred to the Golden Time Hospital. And most treatment usually performed in the Golden Time EDs. So these are the distribution of the 26 hospitals in Seoul, capital city of Korea. And in this program, we also provide education for the EMS personnel about proper assessment of trauma patients, recognition of severe trauma cases, and on-scene treatment. And as I mentioned, EMS personnel judge whether the patient has severe injury or not. So among the patients with injury severity score 16 or higher, 58.9% of the patient was judged as severe trauma by EMS in pre-hospital level. And also we are doing education about on-scene treatment and proper hospital transfer decision. In case of severe trauma, Seoul has another program to deliver the definitive care to the severe trauma patient, which named Severe Trauma Final Treatment Centers. I'm gonna talk about Seoul, more about that. Population of Seoul is about 9.6 million in 2020, which is 20% of the total population of South Korea. But there is only one designated level 1 trauma center in Seoul, National Medical Center. So it seems it is hardly covered all the severe trauma cases in all over the city. So Seoul Metropolitan Government also made a program named Severe Trauma Final Treatment Center. So among the 26 hospitals, 3 more hospitals were selected to be final treatment center for severe trauma. So totally 4 hospitals work as trauma center for definitive care in Seoul. And this program supports the hospital to hire the trauma surgeons. So these hospitals can make the trauma surgeon team for their own hospital. And this program starts substantially from November 2020. In case of severe trauma patient, the patient initially transferred to the nearby Golden Time hospitals, and initial treatment and stabilization is performed. If the patient can provide definitive care for the patients, if the initial hospital can be provide definitive care for the patient can be treated in the initial hospital. But if not, because of the personnel, device, or ICU beds, a patient can be transferred to one of the 4 final treatment centers. And they can provide definitive care with specialties such as general surgery, neurosurgery, thoracic surgery, orthopedics, and intervention medicine, etc. So I try to analyze the effect of the program. I try to compare before and after the program. So using the National Emergency Department Information System Database, which named NEDIS, which monitor every ED visit of the Korea. So patients, patients that ED with trauma were selected who are 15 years old and older, with mechanism of traffic accidents, fall, stroke, penetration, or machinery injuries. And to figure out the outcome of the final treatment, ED visit which ended up with transfer were excluded. The outcome would be mortality of the trauma patient, but as Dr. Sata mentioned, we cannot compare mortality rate directly because the severity of the patient can vary according to the hospitals or years. So I tried to calculate double score for the hospital mortality. So these are the eligible cases. In Seoul, there are about 150,000 of cases. And in 4 severe trauma final centers, 110 to 18,000 of cases every year. This shows the graph for the percentage of the patients with injury severity score 16 or over, which is calculated by ICD-10 diagnostic code. And after the program, it's around 2020, it seems that the severe cases going steeply higher in final centers. So it means the severe cases gather to the 4 trauma centers. And I compare the double score for mortality. It can be calculated as shown down there. It means the number of the unexpected survivor per 100 patients. So, and the expected survivor can be calculated using TRIS. So TRIS can be calculated. TRIS means actually the probability of survivor, so which is calculated with the equation below. So if the double score is higher, the survivor rate is higher even after severity adjustment. So this is the equation for the TRIS calculation. And I use the equation and coefficient according to the NTDB 2010. And ISS were substituted by EMR ISS. So the probability of survivor calculated by TRIS are shown in the graph. In the red line. In the red line in 4 trauma centers, after the program, right after the line, probability of survivor is steeply decreasing, which means the severity of the patient is increasing in these hospitals, and also means the severe cases are gathering to the trauma centers after the program. So after that, I compare the double score, the final outcome. Double score is increasing in 4 centers after the program. But unfortunately, the overall score in Seoul did not so increased. And we, so unfortunately, the overall score in Seoul did not so increase. So but we are planning to continuously follow the outcome. And there remains a question: how can we transfer the severe trauma patient from initial Golden Time Hospital to the final treatment center safely? So I'm gonna explain about the Seoul Mobile Intensive Care Unit, which is inter-hospital transfer system in metropolitan area. About 9 years ago, inter-hospital transfer system for metropolitan area of Korea was created, which is named Seoul Mobile ICU. In case that the patient did critical care and is unstable, but there is no ICU in that hospital. Originally, there was no way to transfer the patient to other hospital by regular ambulances. But after the implementation of the program, the specialized ambulance for the critical care with an emergency physician, a nurse, and an EMT can safely transfer the unstable patient between the hospitals. So in case that the severe trauma patient should be transferred to the final treatment center, this SMICU provides safe and seamless transfer of the patient. So this is the picture of the ambulance, and there's quite large space in the ambulance. So you can do various procedure in the car. And recently we, the SMICU transferred 100 the case of severe trauma patient to the final treatment center. And this shows the group chat room used to activate the severe trauma patient transfer. In case of severe trauma, SMICU is sometimes asked to arrange the final treatment hospital. So by communicating among the SMICU physician and 4 centers, prompt decision for inter-hospital transfer is made. And in the SMICU vehicle, there are several devices for severe trauma patients, including critical care monitoring system, portable ultrasound, and long backboard or cervical collar and scope stretchers for immobilization the patient, and the rapid infusion system for RBC transfusion for the patient. And this is additional slide that I originally did not put it in the slides. So there's a helicopter transfer protocol cooperated by SMICU and Fire Agency of Korea. And this protocol is for a long-way inter-hospital transfer of the critical patients, mostly from outside of the metropolitan area into hospital into Seoul. So SMICU teams and EMS get on the helicopter from Seoul and move to another region to pick up the patient and transfer the patient to the Seoul safely. So this is me getting out of the helicopter. So this is the final slide. In Korea, EMS has a written form of pre-hospital procedure protocol and transfer protocol. And to provide definitive care for the severe trauma, a final trauma center of severe trauma can be the choice. And there's special ambulance team named SMICU and can provide safe transfer to the severe trauma patient. So this is the end of my presentation. Thank you.
Yeah, thank you very much for your presentation. Next topic, I would like to invite Dr. Nguyễn Vinh Anh, Dr. Department of Emergency Medicine, Chợ Hospital, a lecturer, Department of Emergency and Critical Care Medicine, University Pharmacy and Medicine, Ho Chi Minh City. Yes, please.
Good afternoon, everyone, and I'm very thank you. It's such an honor for me to be here today to talk about the trauma care in Vietnam. I'm a little bit sorry at first because there's a kind of a misunderstanding about the concept, the subject of this presentation, that you're talking about the trauma system, and I'm just talking about the trauma care. But however, I will integrate the information of the trauma care system during my presentation. So you all know that we kind of a low and a middle income country, and trauma is such a huge burden. We already said this morning, but how about the trauma, the trauma care system here, just the same, because pre-hospital care, the care in the ED part, and the trauma care, I mean the trauma surgery care, the trauma ICU care. However, the rehabilitation care and the psychiatric care is still is a thing that I really want to emphasize in this speech. Also, I'm talking about a little bit from the for the vulnerable population, and also the data registry, data audit, and also for the trauma training. Sorry. So for the first aid and the initial treatment, mostly provided by the lay rescuer, especially for the rural and mountain areas. In there, the kind of the EMS in the rural provinces is fully equipped. I mean that, and to call for the ambulance to go out there is much takes a longer time for the lay rescuer to bring the patient to the hospital by themselves. And so the first aid may be not fully not appropriate, and in some cases would be harmful. However, once they get into the district and the provincial hospital, they would be get a better care, the better care. However, besides the Bạch Mai Hospital, Việt Đức Hospital, and also some hospital in Ho Chi Minh City, in the most of emergency department in Vietnam, just about the general practitioners only, with different levels of trauma care training, or maybe not at all. So the doctors that specialize in trauma care, in resuscitation, also just located in the major central healthcare centers. And that is a huge gap between the rural area, the trauma care in the rural area in the first golden 6 hours, and the later phase of the trauma. So here's a real image. The real image is very heartbreaking also, very heartbreaking. This is a patient that Chợ Rẫy, the emergency department of Chợ Rẫy Hospital received at the sixth hour after the major trauma. She is transferred directly by the lay rescuer. The problem is that the family patient already called the 115 system at that province, but then the 115 province, the team suggests that she should be admitted to the nearest hospital. The family don't accept that idea. So as the require of the family, the patient be transferred directly 6 hours without any pain control medicine, just the fluid, a lot of fluid. And you know, a lot of fluid means bad consequences. We all know that. So for the acute care quality, we have some of the survey made by the GICA from the 2008 and for up to now, and the most is, and I have been searching for but recently I don't have, I cannot find, there's not much information of a survey or data about the acute care quality. So we have two private, the EMS and the non-EMS. It means for here, we call EMS. It means that just all the things that related to the 115 system, and the other side is the private ambulances, the private or maybe the public transport can be used as a set of them by the EMS. And therefore, 63 of them were admitted within the first 6 hours only. And some of them, 8% of them were admitted after 72 hours. Then, however, the number is not improved yet. In 2008, just 4% of the trauma patients were transported by the ambulance. And the most significant thing here is that 42 of the RTI victims died before reaching a healthcare facility, compared with 29% in the hospital. So that we need a survey on the acute care quality and how to improve that. The nearest, the latest data from Việt Đức Hospital, which is also in the PATHOS registry, For now, in 2021, there's a lot of improvement. They receive first aid in a health facility, but 96%, and 98%, all of them was transferred by the ambulance. And they also receive during the transfer all of the procedures needed, such as the catheter, airway management, cervical immobilization, and bleeding control in approximately 40% of cases. However, the emergency surgery rate is 42%, with the ED mortality rate is 24%, which is a very concerning number. So for the traumatic, our hospital cardiac arrest, and it's just only 0.9% of them survive with a good neurological function. And this is the thing that we consider a lot of improvement in the future. And all of the traumatic OSCA witnessed by the bystander is 31%, and all of them nearly almost all of them have a CPR taken by the bystander. However, only 26 of them, just 26 of them was taken by the EMS, and for the rest, they are die on scene because they're waiting too long for an EMS, or maybe the harmful intervention that given by the late rescuer. So from the data from the emergency department of Chia Hospital for the period of 2022 and 2023, we have identified 6 scenario, the most frequently scenario for the cardiac arrest that on arrival. It means that you just enter the ED and they have a cardiac arrest. So first of all, the uncontrolled bleeding. Just like that patient have an unsecured airway, tension, pneumothorax that have transferred for 2 or 3 hours without the decompression, a critical brain injury, the massive crystalline resuscitation, and also we have a lot of cases of deadly hyperkalemia because of crush syndrome that without any support during the long transfer time. So about say something about the trauma care system here. That first of all, we don't have a strict system distribution as in your presentation. Actually, I feel overwhelmed and so amazed by the the very wonderful trauma care system in your country. The decision to admit it to the hospital or not is based totally on the family. And some of them, the patient is so critical that the family want to transfer them as soon as possible to the farthest hospital, but they think that it would be trustful, for example, for Chia Hospital, so that they don't receive the emergency procedures or emergency stabilization during the golden hour. So when they arrive in Chia Hospital, they miss the golden hour and they all turn into the massive resuscitation with crystalloid and the refractory traumatic shock. So, and from our data, we have the pre-hospital fluid in 66% of all cases, and with a median of 1 liter of crystalloids. And however, in 42% of cases, the volume of fluid is not retrievable. And the fluid volume in the first 24 hours, 15% of them receive more than 5 liters of crystalloid. So according to the data from BATOS 2022, that for the data in the BATOS is just included only the public EMS transported trauma patient, not from the private one or maybe the lay rescuer one. So here the data from Chia ED, we included all kind of the trauma patient admitted to the ED. So how about what happened inside the ED is for you, for Malaysia, for Korea, for Thailand, you have a trauma team, I suppose. You have a trauma team and a resuscitation team. The difference here is that if the trauma patient arrive in the provincial ED, the surgeons will be kind of from various specialties, maybe from GI, maybe from neurosurgery. No one be trained in trauma surgery only. And for the central hospital ED, it's just the emergency physicians. Just about 1/3 of them will be specialized training in trauma care. So because of that, the surgeons are from various specialties. They resuscitate the patient by the surgery principle, not by the critical care or not with the critical mindset. So that leads to a lot of consequences on complications on trauma patients. The trauma surgery is another aspect that I've concerned that trauma surgeons would be from multiple on-call doctors at that night, but no one will take the lead that to decide that to operate or not, and they would be transfer from specialties to specialties separately to take care of different injuries. And because of that, for the damage control surgery, we don't have, up to now, we don't have a protocol or any principle for the damage control surgery. They take the surgery for the in the acute phase of trauma, just ordinary surgery. So data from the Charity Hospital 2020, the polytrauma or the traumatic shock have the immediate surgery, but lasts more than 4 hours in the median. Some of them will take 6 to 8 hours to repair in the acute phase of a trauma. And but the decision is that all of the surgeons want to repair almost every injury in the first time, in one time. So that makes a very long time, and a very the impact of the second hit will be hugely, will be very such a predisposing factors for the patient to multi-organ dysfunctional syndrome, maybe. And for the rehabilitation here, we just according to the WHO report, just 2% of our trauma patients can have an access to the rehabilitation program, and this is decrease the capacity of the patient to return to the normal life and for the normal activity. And this is the post-trauma part that we should focus on. And we have a lot of vulnerable population in the trauma, especially here is the elderly. From the Việt Hospital, the 19 care and the mental care should be matched together to prevent kind of a prevention for this vulnerable population. They also a report in a survey in 2022 that say that name some of the barrier for the elderly with trauma patient come to the ED for cost barriers. Second is with so few geriatricians, and for the trauma patient, the treatment of the elderly trauma patient is not a holistic way. So the surgeon would treat the injury, then the medical they treat on the comorbidities, but then not geriatricians to cover all of them, especially for the mental care. So that leads to the very low quality of life, both for the physical and mental health issue and the recovery to the normal daily function. and this is more significant in the vulnerable groups such as unemployed, living in the rural or the mountain area, and someone with a lot of comorbidities and not covered by the health insurance. So we need a better, we here in Vietnam, we need a better understanding of the degree of impairment, not how many trauma patients that we can save their life, but also how many trauma patients that we can save their functional life, which would be a major idea to improve our health system. So this is a way to effort. And one, beside these trauma training, which is we are lacking of the trauma training, one thing that can be deduced from the PATHOS report in 2023, you can see that you can see that there's the number of the trauma patients from Vietnam is more than 13,000. However, the actual number of trauma patients from Vietnam can join the study is just 600, which is less than all. It is a list from between the four countries. So, and with a very high mortality also. So what I can say that from this part is that, and the missing data is accounted for more than 9,000 patients. So that we really need a trauma data collection and audit also. Just like our colleague from Korea has provided a kind of data registry, the data for the trauma information collection that can be accessed for every time that we make a survey or every time we make an audit. So, and it can be have a kind of freely access to every doctor of every health personnel, so that we can improve our understanding and improve our kind of build the motivation to really run and practice the trauma care. That's what I want to say. A good audit will lead to the improvement. So thank you very much.
Okay, thank you very much for nice presentations. So we have a couple of minutes from the discussion before the break. Do you, and at the floor, did you have any questions or comment from we have five speakers, 5 countries on the floor. Did you have any question?
Việc là mấy đứa dịch lại nghe. Cái đợt này em mình đi là mình có mời cấp cứu 115 với Sở Y tế tham gia không em? Tại vì sao tất cả những cái chiến lược mà để mà dự thảo ra các cái vấn đề mà liên quan cho đến cái hệ thống cấp cứu chấn thương cũng như cấp cứu ngoại viện đó hiện nay thì là bên 115 và bên Sở Y tế sẽ là người chấp bút. Cho nên là nếu như mà nghe được những cái này để làm chi, để cải thiện về chất lượng của hệ thống cấp cứu thì nó tốt hơn. Thì hiện nay là mình nói với nhau nghe vậy thôi, chứ còn để mà có thể triển khai thực hiện được thì phải có những cái người ở trong cái phần mà triển khai thực hiện. Thì trong đó thì nó có là hiện nay là có cấp cứu 115 và cái vai trò của họ ở thành phố này rất là lớn. Đợt vừa rồi thì họ tổng kết các cái việc mà họ làm là rất là nhiều. Trong đó là giảm được tất cả các cái thời gian mà để mà tiếp cận với lại những cái bệnh nhân chấn thương hoặc là những cái trường hợp mà thảm họa. Ví dụ như những cái trường hợp mà chúng ta thấy rằng cái chấn thương hàng loạt ở những cái khu vực như là cao tốc hoặc là một số các cái trường hợp mà ở những cái khu vực mà có những cái tai nạn giao thông mà hàng loạt đó, thì tất cả các hệ thống cấp cứu chấn thương cũng như kết hợp với lại quân đội đó thì chúng ta cũng đã giải phóng và cấp cứu được kịp thời. Thì cái này đáng lẽ nên có cái bên cấp cứu 1 năm có một cái bài kỹ hơn về cái hệ thống mà đáp ứng về EMS của Việt Nam. Chứ còn mình nói thì ngay như Chợ Rẫy hoặc là một số các cái bệnh viện lớn ở đây á, thì làm chúng ta là level 1 rồi, tức là những cái trung tâm cấp cứu chấn thương tuyến cuối rồi. Cho nên là cái việc mà chúng ta tổ chức thực hiện cái ba tốt nó được tốt hơn á, thì cái đó là phải có nhiều các cái biện pháp cũng như là những cái team để cùng nhau làm cho cái chất lượng của cái hệ thống cấp cứu chấn thương của Việt Nam nó mới tốt hơn được. Bên Huy có thêm cái tham luận gì không về của Việt Nam á?
Thank for your comment from the Professor Thảo. Today, I invite most of Sai province and hospital in Ho Chi Minh City and province hospital health center from Ho Chi Minh City and 115 center. But today, when I have the signature from the participant only to the 115 center. Yeah, and it's the purpose of battle. And this time, the first time in Vietnam, we can want to connect so many high not only level 1 hospital, 115 center and another district hospital, most of in private hospital. Yeah, I only invite all of you come here because I want to improve the bystander and pre-hospital care. So it's dependent on the first step. Yeah, when you want to build up and want to improve your our trauma care system. Yeah, thank you, Professor Pat.
Okay, and any comment, Dr. Shin? Okay. Okay. So we don't have a time now, so it's time for the break. Thank you very much for your all. See you next session.
Before the break, we invite Dr. Parinya Thanwabun, Dr. Min Woo Kim, and Dr. Win Min go on to the stage to receive the certificate from host. Please. Welcome to the stage, Dr. Phạm Thị Ngọc Thảo and Dr. Satya Riyapan. Ladies and gentlemen, before going to the section for building the Vietnam's trauma care system and clinical research network, we have a 20-minute break. Okay, you can break and get back here at 30:40. Yeah, thank you.
The reasons. Okay, the first. Okay, sure. Have this one. I have this one as well. Okay. Excuse me, everyone. Just to get 5 minutes to summarize that in the morning we can do the BBM challenge, use the background math with X-series advanced. So I will show you who is the best performance. You will get a prize. Okay, the best performance is Dr. Trung. Yeah. This is summarized from the data that we collect that I want you to do the background math. Okay.
Dạ vâng, hồi sáng đó là chúng ta có một cái challenge, cái thách thức về bóp bóng bóp thông khí ở bên ngoài ấy ạ. Thì ở trên đây là cái kết quả về những cái thông số mà ghi nhận lại, và đây là cái kết quả tốt nhất từ bác sĩ Dương ở bệnh viện Tân Phú ạ. Xin mời trong tràng phát tay dành cho bác sĩ Dương ạ. Xin mời bác sĩ Huy ạ. Dạ dạ. Dạ dạ.
Under 1 billion Vietnam đồng. Yeah, the value of price is under 1 billion Vietnam đồng.
Thank you, Dr. Huy. Xin cái file tiếp theo ạ. Xin cái like tiếp theo. BBM gọi là cái BBM gọi là cái việc và cái kết quả tiếp theo sẽ là cái FT mà CPR.
So this one is a CPR challenge. I will show you some data. Even everyone perform, we can zoom and make to read the result like this.
Mỗi lần FT, mỗi người mà FT á, thì chúng ta có những cái dữ liệu ghi nhận giống như là ở trên màn hình ạ.
Okay, this is summarized of the everyone, single one. We can track for the performance of the compression, depth, and recoil. So this is a summarize of each individual, the single of the nominate to challenge. This is the winner.
Và đây là cái dữ liệu ghi nhận lại cái người chiến thắng, đó là bác sĩ Nhân ạ. Ở bệnh viện Thống Nhất, xin dành một tràng pháo tay cho bác sĩ Nhân ạ. Dạ. Và xin mời dạ Dr. Sata.
Yeah, Dr. Sata.
Yeah.
So you can see her chest compression fraction is 94%, average rate is 110.
Dạ
Yeah,
vâng.
this is the summarize of the data. That is how good that she did. Okay, thank you so much for your time.
Dạ, cảm ơn tất cả các quý bác sĩ ạ. Và các dữ liệu đã được ghi nhận và chúng ta thấy là bác sĩ Nhân đã có một cái kết quả CPR rất là tuyệt vời, lên đến 94% so với các tiêu chuẩn của AHA 2020 ạ. Một lần nữa xin quý vị dành một tràng pháo tay cho hai bác sĩ chiến thắng của chúng ta là bác sĩ Nhân và bác sĩ Dương ạ. Xin cảm ơn.
Dr. Yang is the EM doctor of Thông Hospital, and her duty so many cases got coming. So this is has a good skill is downstream. Yeah.
And now we will continue with section 4, the building the Vietnam trauma care system and clinical research network. We would like to invite Dr. Brian McNally and Dr. Shandu Sin to moderate the section.
Hello. 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 Okay. So now we are starting for section 4. The title is Building the Vietnam Trauma Care System and the Clinical Research Network. I'm very honored to get the chance for moderating together with Dr. Le Bao Hui. Yeah, he is, as you know, that he is a very important person in the pathos, Vietnam principal investigator, and then he is hosting this conference today, and then he will talk about the recommendations on building up the Vietnam, the trauma care system. So welcome, Dr. Le.
Yeah. Good afternoon, ladies and gentlemen. Yeah. I'm really appreciated up to now for a long time from this morning. So many participants still stay here to follow our topic. And my topic is how to build up the Vietnam trauma care system. And for this morning, you heard about so many information, so many opinion about the trauma care system from another country, also in Vietnam. And we had some information from the Level 1 Trauma Center or Level 1 Hospital to another, from the very high or advanced trauma care system, from the lecture from the Professor Brian or from the Singapore or Korea. And also some situations like Vietnam, for example, Malaysia and Thailand. And in our country, we had the area 30,000 kilometers square, look like the Malaysia. And we had the large population with around, up to now, I think it's 100 million people. And this got the fourth in Asia and the 54 in the world. And as you know, we had the mechanical moving of the population to move the urban. So the urban population increasing quickly. And if we have the large population, and increase in our rabies quickly, rabbit the increase in the population. We have the challenge, we have to face with the risk, increasing the risk of in the children and in the elderly patient. They have easy to damage from the trauma, injury, or violent or drowning. And we have some information from the report of the lecture from the Dr. Vinh Anh, Dr. Lê Phước Đại. And in Vietnam, traffic accident and drowning remain the leading causes the mortality or death in Vietnam. Every day we have the information, we have the around every day 3,600 injury victims and around 90 cases of death. And most of them are road traffic injury. The road traffic injury is the leading cause of death among those aged between the 15 to 29 years. It's the young people. And how about the structure of healthcare facility in Vietnam, as you see in the picture? Most of facility or hospital to focus in the urban and in the north. In the Mekong Delta and in the Ho Chi Minh City or South Province is the later than. Yan Quang Hospital. Hanoi, the capital, is expected for this is the last share on the bit funding to improve. So we need to give more sharing this resource. And we have the 4 levels in public hospital. It's the central level. Under the Ministry of Health, we have around 50 hospitals. And the provincial level in around 400 hospitals. And district level is around 700 hospitals. And the 4th is the community level. Besides the public healthcare service, we have the private hospital. It's around 200 private hospitals. And day by day, we have the more and more important role in the healthcare service in the Vietnam. But mostly, they located or the focus in the urban. So we have the most of facility, most of hospital to focus in urban. And the near or the another area had the less the equipment, address the human resource. For the trauma care center, for every big city, we have only one or two center. And the level 2, we have the in the level 1 hospital for the central or local, and the level 3 or level 4, they also be in the level 2 hospital of province and or district hospital. So we have here the information, the picture of the traumatic or the deaths of in Vietnam caused by the trauma. We know we have the lack of specialized trauma hospital and level 1 trauma care. And for example, at the topic of the Professor Saparia from Malaysia, they had the plan to move the coordinated center and pre-hospital to beat the victims from the center to the hospital dedicated care. But in Vietnam, most of patients, not of victims, look like the report of the Dr. Vinh Anh. They want to move to transfer to the level 1 center because they think They had so many equipment, so many good doctor look like the report of Dr. Dai. And what the problem? The liver one, so we see many patients, many victims, but not severe liver, so severe severity. So they overload, but they cannot supply the fulfill or the correct or appropriate for most of the victim. And how about EMS? Up to now in Ho Chi Minh City, up to now in Vietnam, the 115 centers, so many more and more to build up satellite. For example, in Ho Chi Minh City, from the 3 satellite 115 center, up to now we have the 41 satellite. So in this data from the battles 2017, we received the most of in my data, my hospital, we received the most of case come to ER by non-EMS. It's at least 98%. But up to now, it's a subchance. We have at least 20% up to now. It's a big change. And another resource. For example, for the who staying there, we need one ambulance for the area with 1,000 inhabitants. But in Ho Chi Minh City or in Hanoi, the biggest hospital, the biggest city in Vietnam, we only less than 0.5. We look at the another city in Asia or Asian. In the come to our ER for this land, we have the 12 ambulance, but in the public hospital, they have a responsibility so many missions, not only beat the patient, not only for medical service. And as you know, the components of the trauma system are the forest at the another report. It's the 5 bystander care to provide the early first aid for the patient with the heart to see the sign of the victim at the scene. And up to now, who responsibility for this? They have no, because some school or the Red Cross to give some training for this, and pre-hospital EMF care to stabilize vital sign, vital function before they bring the victim to hospital. But it's a have no program, training program for standardized most of things. And only based on the 115, the public center or private 115. So we have not yet standardized. And the hospital definitive care is also. Most of victims want to move to level 1, level 2 hospital, level 1 going to trauma center. And some hospital, they have no received the victim and to depend to send the severe victim to the higher level. And how about the rehabilitations? In Vietnam, we lack of the rehabilitation for the patient. In the patient come to or inpatient, it's the same. It's the same. After operation, the patient have no have no advice, have no receive rehabilitation in hospital, most of case. And how we can return, how we can to send, how we can to help the patient to come to into the society and come back their work. So very important. I think also the government has some change in policy, but as the Professor Thảo told me that most of definitely care hospital, level 1 or level 2 center, trauma center, yeah, only use, cannot solve most of things. We need to pay attention more and more with the importance of pre-hospital care. And pre-hospital care needs to be the simply component of the trauma care trends of survival. For the prevention in this survival chain in trauma, you know, we have the not called coordinator center, trauma center, to run, to solve, to guide, to direct most of activity. And not only one component, we need to combination, to coordination, to collaboration, and we need to think the patient become the center of our care, especially in the trauma system. If you think that, you can change your mind, you can you can give us some more and more solution, and you can call the cooperation from the most of the human resource. If you have the ethical, you have the legal, you have the finance, and you have the technology. Using, for example, for PI, for example, telemedicine, for example. But how to use most of the resource. And if you have the data, you have the data, big data for this trauma care system, we cannot useful to to solve the problem, to develop the program to solve entire problem. And as you know, the trauma education is not the standardized. From the academy, from the society, they have the different. Yeah. At that time, we need to work together. And if we work together, we put a strong voice, strong teams, and strong strengths. For the nation trauma care system, the role of the leader. Most of us EM doctor stay here. We are the practical, like the Dr. Dai said that. But there are so many things we need to run the leadership. I told the Professor Thảo that I and our colleagues, our staff, we practice every day. But if you want to train in the government, we need the nation level leadership from the Ministry of Health, from the medical university, for example. And we need to use the resource from the military leadership and the sector leadership. And how about the nation level leadership? They need to establish the nation trauma care system, and it made answer the development of common the best practice. We can collect, we can have the business data standardized, we have the resource, and work for across the continuum of trauma care. We have the convent, governmental, youth academy, and private sector. We ensure appropriate funding and the reduction of regulatory barrier. And also, we have the strategically community to value the nation trauma care system. And how about the military leadership? It's for a long time in Vietnam, it's a system had abundant resources and a personal, equipment, and budget. And they had the system will respond quickly and regularly training. And in Vietnam, we have the traditional, the opinion, a close military and civilian relationship. And if we have the cooperation between the military and civilian, it's useful for research, infrastructure, and training. And how about the civilian sector leadership? There are no coordinating center for emergency care trauma, including hospital, in-hospital and post-acute care. So many crowded, so many confused. When you receive a call from the 115 satellite to call my ED, receive or not? We have enough time to discuss more and more because so many patients wait at time. If we have a little the patchwork of the trauma care system. So standardization and continuous training for trauma care is not synchronized, as you already talked in. So we need to suit including coordination between the government and in the provincial and local health sector and academy from the university, medical university, and the expert, and private sector partner. We should attract care from the SEN to acute care, rehabilitation and post-acute care, and we need help to design native locus of responsibility, and it should build up the trauma moderator center and developing and implement the guideline for the lower level to follow up and guide them with patient who can move level 1, level 2, level 3, for example. And we know the human resource equipment or most often can supply it. So if we have the good relationship between the civilian trauma system and military trauma system, we share the infrastructure, system design, data, best practice, and personal. And the last, if you have the most something move smoothly, but you have the center to use the data and use it for the develop or improvement the healthcare service in the trauma care system. Conclusion, I think we built a trauma care system in Vietnam. Up to now, still challenges, but it in processing and integration. And very important, the role of leadership. Then trauma care coordination center under the supervising and direction of government can optimizing resources, building a big data system, training and coaching, and promoting international cooperation. Thank you.
Dr. Le, thank you very much for your presentation. We will have some discussion after the one more speaker lecture, and then could you go to your seat? And then next, please.
Yeah. Next speaker is Dr. Hung. He's going to talk about how to build up an EMS-based trauma registry. He needs no introduction. He's famous.
Good afternoon. Thank you for introduction. I'm Dr. Hong from Seoul National University Hospital, Seoul, South Korea. I will introduce how to build a EMS-based trauma registry based on experiences in South Korea. This is not updated files. Yes, this is an updated version of my slides. Okay, I should spend time with the PowerPoint slides now. Okay, thank you. First of all, I'll briefly introduce Korean emergency medical system for trauma care. So we have only one EMS agency across Korea under National Fire Agency government body, and we have single dispatch number for 119 for fire, rescue, and EMS. Our EMS model is a public model by charge of free, and it is financially supported by tax government budget. And we are fixed ambulance operation, and our scope of EMT for trauma care is EMT intermediate. So our EMTs can perform advanced airway, intravenous hydration, cervical immobilization, but they cannot perform transfusion or giving some drugs or needle thoracostomy. And our EMS operation is based on BLS single-tiered model, and partially two-tiered model is operated for out-of-hospital cardiac arrest and severe trauma. And almost in South Korea, we have 16 provinces, so usually one dispatch center for each province cover all EMS calls for trauma, out-of-hospital cardiac arrest, and many disease conditions. This is trauma case volume in South Korea. Annually in South Korea, about 1.7 to 2 million cases visited ED due to trauma. Among them, 50,000 to 70,000 cases are EMS assessed severe trauma cases. And patients with injury severity score equal or higher than 16 or cardiac arrest cases around 10,000 cases. This is annual volume of severe trauma in South Korea. Trauma care system monitoring is very important to improve quality of trauma care and to improve save life due to severe trauma. So from injury prevention, pre-hospital care transport, hospital trauma care, rehabilitation. So all four chain and integration of this kind of care system is important. One key item of this trauma care system is a regional trauma center, because a regional trauma center can perform fast, intensive, focused, and specialized final definite care to severe trauma patient. And they can also perform specialized education and training course for trauma team. And they also can build a regional trauma management system. In South Korea, we designated level 1 trauma center across countries. From 2012, our Ministry of Health and Welfare designated the regional trauma center benchmarking level of trauma center in advanced countries, like American College of Surgeons in United States or Japanese trauma centers. Now we have total 17 level 1 trauma centers across country, and we used many money. And initially, our preventable trauma death was around 50% in 1998. It means about half of mortality due to trauma was preventable, basically. After implementing this trauma center designation program, it is rapidly decreased to around 15% in 2019. During this period, we have several trauma registry in South Korea. The first one is Korean Trauma Data Bank, KTDB. It is similar with the National Trauma Data Bank in United States or Japan Trauma Data Bank. This data bank is basically hospital-based registry. So cases who were transported to 17 regional trauma center, level 1 trauma center is enrolled in this registry. In 2021, total visiting patients for level 1 trauma centers were around 34,000 cases. And among them, cases with ISS over 16 was 8,019 cases. The National Emergency Medical Center is under Ministry of Health and Welfare, produced the annual report, and this data will be available soon. And another database is Emergency Department-based injury in-depth surveillance. This is operated by Korean Disease Control and Prevention Agency, similar body with the CDC in United States. And 23 emergency departments across South Korea participated in this program. So KDCPA and 23 emergency departments cooperate for this surveillance. But in this surveillance, mild to severe injuries included, and this database usually focuses on injury risk factor identification and injury prevention. But these two databases produced from hospital-based manner. So how can you measure community-based quality of trauma care systems? So with fire agency, fire department, it is a pre-hospital stakeholder. Based on this body, we can collect pre-hospital information, and we can capture initial candidate for data collection using EMS run sheet, CPR registry, and so on. And then our Korean CDPA and our team dispatch medical reviewer to each hospital, and we can collect in-hospital data system together and merge this pre-hospital and in-hospital data together. We spent about 15 years. So initially we started this process from observational study with EMS run sheet and hospital medical record from several provinces, and we expanded to nationwide manner. And we added more intervention study and more in detailed registry, and then we can make more proficient database, and we can make more quality indicators for OHCA care from pre-hospital to in-hospital field. Based on this experience, we tried to develop EMS-based trauma registry in South Korea. This is the main concept of our registry. So this is EMS-based, so pre-hospital sector-based registry to collect information about severe trauma. So initial inclusion is a suspected severe trauma case in EMS run sheet, assessed by pre-hospital EMS provider under National Fire Agency. And then we also made efforts to make collaboration between Korean Disease Control and Prevention Agency and National Fire Agency. And we recently released entire database to public for research or quality improvement or policy development. This is case enrollment criteria of EMS-based registry in South Korea. So first one is a suspected severe traumatic injury. So this is basically originated from a field triage scheme in CDC from United States. So first is abnormal physiologic criteria, abnormal revised trauma score. So if the patient have altered mentality, measured as VPU by AVPU method, or their systolic blood pressure is under 19 millimmercury, or their respiratory rate is under 10 or over 29, so their physiologic status is unstable, they can be enrolled in this criteria. And another one is a serious anatomy, such as chest instability, proximal extremity amputation, and so on. And third criteria is a serious injury mechanism like high-risk auto crash or observed mortality in same passenger compartment. And last one is a clinical consideration like high geriatrics or pediatrics, pregnancy, or many medications. So if the patient satisfies this field triage scheme of injured patient or EMT have some suspicion of major trauma, they can be enrolled in this database. And another category is suspected severe non-traumatic injury. So injury mechanism is poisoning, drug overdose, many suicide cases in South Korea, and asphyxia, burn, drowning could be enrolled, and also abnormal RTS could be candidate. And third category is mass casualty incident, so to collect severe trauma cases from disasters. So if 6 or more casualty is observed in a single accident, these cases are enrolled in this EMS-based severe trauma database. We have around 10 years of development period of this Korean severe trauma registry. Initially, from 2012 to 14, we started to develop a basic concept of this registry for several provinces. So we selecting some candidate of variables. We develop education course for medical reviewers, and we decided how to collect the data and how to make IRB or some collaboration with the National Fire Agency and Korean CDC. After that, fourth project in 2016, we expanded to nationwide data collection system. We assessed the feasibility of this data collection in rural area, very distant area, and small hospitals, and so on. And fifth project in 2019, we started to track transport cases. So in South Korea, many cases transported due to severe trauma is transported to another hospital after initial resuscitation for higher level of trauma center for surgery or ICU care and so on. So we want to track and measure final outcome of these cases after transfer to another hospital. And then during 2020 and until now, we are maturing this database collection system, and we developing new quality indicators and so on. This is a data collection process. So initially, we extracted cases of eligibility from National Fire Agency database, and then we send medical record review for in-hospital care and clinical outcome data collection. So our target hospital is level 1, 2, 3 emergency departments. In South Korea, our government designated each emergency department by 3 categories, level 1, 2, 3. And we are excluded cases transported to non-registered EDs, local outpatient clinic or small hospital and so on. We are performing 2 kinds of manner to collect in-hospital database. So first is direct visit. If annual case volume of the hospital is over 20, so many cases are transported to the hospital. We dispatch medical record reviewer to the hospital, and they collect information at the scene. But if the annual case volume is very small, under 20 cases, we are performing indirect visit manner. So we collect database from fax or email or such kind of amend online manner. And then we are performing quality assurance process. So we are operating regularly education and training program for medical reviewers, and we are developing medical record review protocols, and monthly QA meeting, and we are performing feedback to each reviewers. This is current database collection status. For example, in 2020, total eligible patient is around 46,000 cases. Among them, suspected severe traumatic injury was 26,000, and severe trauma injury with ISS over 16 was 8,000 cases, and available information for calculating probability of a survival for TRIS and W score was around 7,000 cases. We are trying to continuously develop community trauma key index. We want to compare performance of trauma care between each province. We want to also continuously track improvement or worsening of trauma care performance in each region. This is some example of our indexes producing from EMS-based severe trauma registry. This is the number of EMS-assessed suspected severe traumatic injury. So left side province is metropolitan and urban areas, including Seoul City. And right side areas are rural area, including Jeju Island. So as you see in Seoul, around 4,000 cases are collected annually, but nearly consistent data collection is performed. But as you show in this graph in Chungbuk area, some regions show an abnormal number due to increased number of EMS provider reports. So in Chungbuk area in 2019, they have a very highly suspicion of severe trauma cases, some happening of this situation, and then we can assess the situation and make some education and QI to EMT, EMS providers in Chungbuk area. This is the proportion of patients with ISS equal or higher 16 of the suspected severe traumatic injuries. Nationwide, about 20% of this database is with ISS equal or higher 16. But there, you can see there are many regional variation is observed. So in mean, the ability of EMS providers to screen for severe trauma varies by region. Well, there could be some difference of injury epidemiology or severity of trauma could be occurred. This is the proportion of the severe trauma patient admitted to ED within the region. It means if this indicator is higher, it means that region can have sufficient capacity to manage all cases occurred in the region. So for example, in Seoul City, more than 95% of severe trauma cases could be treated inside Seoul City. So Seoul can manage about 95% of severe trauma Seoul citizen, but in Chungnam area, it is decreased to 60%. So about 40% of severe trauma case in Chungnam area, in rural area, they could be transported to nearest really high proportion of a shorter pre-hospital time. It means they can satisfy golden hour from injury to final definitive care. But the rural region shows a relatively longer time, and the total pre-hospital time or region is now increasing because this is during COVID-19 period. So during 2019 and 2020, there is some increasing of transport time. And this is the proportion of the severe trauma patient transported level 3 ED. So in South Korea, we categorized all 500 EDs to level 1, 2, 3. So level 1 is usually tertiary academic hospital, and level 2 is a relatively big general hospital, and level 3 ED is very small EDs without sufficient manpower or without sufficient trauma surgeon or ICU facilities. So our EMS protocol do not permit severe trauma patient to delivered to level 3 EDs. So basically, this should be 0%. And nationwide, this indicator is decreasing from 15% to 5%, and it is a very rare situation in Seoul metropolitan area. But in Jeonnam area, cases transported to level 3 ED is around 30%. So in rural area, we also have a shortage of sufficient medical care resource for severe trauma. And this indicator is the median time from ED arrival to ED operations. Our database included traumatic injury, non-traumatic injury, so many cases. So it means every case don't need to have operation within 1 hour, but delayed hour for emergency operation is not good performance for trauma care in each hospital. Totally, our median time from ED arrival to emergency operation in our database is around 3 hours, but you can see some regional variation of this indicator. So Ulsan City has a very improving of this indicator is observed from 3 to 2 hours, but some rural areas shows increasing of this indicator. And this is W score of each province in South Korea. So W score is calculated by difference of actual survivor and predicted survivor and calculated patients divided by this algorithm. So if W score is positive, it means actual survivor is higher than predictive survivor. So that province save more lives. So grossly, our W score of nationwide is increasing from 2015 to 2020. And for example, in Daegu area in 2020, so their W score was a negative value. It means that at that situation, they will lose many severe trauma cases. We can also compare W score of each level of ED in South Korea. So for example, we categorized our EDs to 4 groups. The first is EDs in regional trauma center, level 1 trauma center, and level 1, level 2, and level 3 ED. As you saw in regional trauma center group, our W score was positive over 3. So it means if patients were transported to regional trauma center, they have an opportunity to save life more than predicted survivor. But if patients are transported to level 3 ED, they can lose lives. So we can monitor this kind of difference from each group of hospitals, and we can also track improvement of worsening of this performance within each hospital categorized group. So these are strengths of our EMS-based Korean severe trauma registry. We can make some regional representative quality indicator could be produced in this kind of trauma registry. And we can also collect comprehensive pre-hospital information. And we also now started to include secondary hospital information for transfer to the patient. And during our experience, we have relatively consistent data collection method, and we recently opened this data to public, so every researchers or policymakers can use this database to improve quality of trauma care system. But we also have some weak points. The first is that it is a rare condition in South Korea, but if patients do not use ambulance, they cannot be captured in this database. And cases visiting non-designated EDs are also excluded for this kind of EMS-based trauma registry. So as you show in Chungbuk area in 2019, if there is some difference of performance of EMS provider patient evaluation and assessment, it can make some bias of this registry. And this is a retrospective design. So if data is not collected in initial EMS run sheet or medical record, it cannot be captured well. And it also has some limitation to identify specific improvement points. And not perfect, but it is an efficient and useful database for national or regional trauma system evaluation. After developing this database, we are also performing severe trauma EMS quality improvement workshop with the National Fire Agency and Korean CDC together. So we started to this workshop from December 2021. So it hosted by National Fire Agency and Korean CDC together, and we organized this program. So based on this trauma system indicator, we give some feedback to our EMS providers, their performance, their outcome, and their weak point together. So we are trying to open this QI workshop regularly, twice per year. In summary, so we developed this community-based, EMS-based severe trauma registry with cooperated National Fire Agency, Korean CDC, and hospital sectors. So we started to open this data to the public. So we are including all injury mechanism, mass casualty incidents. So, and we also tried to add important variables for outcome calculation, like ISS, Glasgow Outcome Scale, RTS, and so on. So we are also trying to develop new community trauma key index. We are developing index and apply it to QI EMS protocol and health policy together. So we believe that this could be a national and regional representative index. We can compare prevalence process outcome between each region or each fire agency or each hospitals. For example, in our quality indicator, regional trauma center shows a significant subsequently better performance and clinical outcome. Thank you for your attention.
Okay. So thank you very much. So now we will have some open discussion, inviting the all speakers standing, please, there. And then Dr. Le is coming to the front. And then we are inviting 4 panels. And then each panels will give us some short advice for the Vietnamese trauma care system development. And then first is Taean Kim. And the second is Ivan Chua. Please come into the place of the venue. And then the Harinya and then Savaria. And then we are talking very open about how can we develop trauma care system in Vietnam. From the speakers, they will give us the good comments, advice. In part of the each subject, Dr. Kim will give us how can we make a good trauma education training in Vietnam first, please. And then I would like to get some discussion from the other people if you have some another idea. Okay, please.
Okay, I thought about the training recommendation in Vietnam. First, I think it's really important to review the existing curriculums and training courses that are already developed in other countries for trauma care improvement. Reviewing the core content and also the purpose of each training courses will be very important, and evaluating the effectiveness of the implementation considering the Vietnam own trauma system. And secondly, looking into the system to select the primary target for the training. The important question will be who will most need the training immediately. I think because the major trauma is very time sensitive, and also the early stage of the intervention is very important for the major trauma. The primary target will be the major trauma patient who how to decide to transport the patient to the designated trauma center. So it was very difficult topic, but we did a lot of offline and online training. We made protocols and we made the EMS worksheet and also the workshops. And EMS provider can do the field triage of the major trauma and decide who will transport to the major trauma centers. And lastly, after that, after the training, analyzing their compliance to the protocol, it will be very important in terms of a performance measure. Observing that they are EMS providers, observing the EMS project actually perform the pre-hospital trauma care, and their decision, whether their decision is correct, will be very important. And if not, giving a comprehensive feedback from medical director or doctors from the hospital will be very important for the quality management. Because if you don't follow up with the EMS providers, the training will just end with just the training, not actual real change of the protocol in the field application of the trauma care. And my final comment about the training is that, in my opinion, the team approach concept is very important in trauma care. The knowledge and the technical skills are also very important in terms of training the pre-hospital providers. But teaching them with the team approach concept will be, I think, it will be the most important, because if they are familiar. If they are familiar with the team approach protocol, they can also provide very good trauma care, but also they can provide very good pre-hospital care of the cardiac arrest and other severe emergent disease. So I would recommend teaching the teamwork and the collaboration skill of the EMS providers. Thank you.
Okay, thank you very much. Dr. Kim provided and give us some advice, a lot of things, but we talk more focus, more briefly. The next advisor is Ivan Chua about what is the recommendation from you to develop the Vietnamese trauma care system and protocol development.
So I think the first important difference is Vietnam is actually a very big country. So importantly, I think the stakeholders need to be involved, whether it is the ministry or is it just within the city itself. So I think importantly, we need to identify the stakeholders, the people who actually make a difference, who actually have some kind of say over the kind of funding that you will get, as well as the kind of resources that you actually get be provided with. And then, of course, I think we need to take a look at the examples from across the world, what kind of systems that they have. And of course, having seen one system, you have only just seen one system because every single system is unique and different. So I think it's important to take a leaf from what other people have done and then try to adapt to your own unique characteristics within the country or even within the city itself. Protocols are all available, over the internet. So importantly, I think you have to look at what you have and then see how you can just try to adapt some of these protocols. You do not really need to reinvent the wheel because all these things are available, but just try to adapt and see how you can help to simplify things and make it easier for the people who need to use the protocols like the paramedics or the EMTs. That's all.
Very good. Thank you very much.
Yeah. Dr. Perry, would you like to speak a little bit about trauma quality, your advice for Vietnam?
Okay, so now I will discuss about the comment trauma quality assurance. To develop the trauma quality assurance, the first, in my opinion, is you have to set the goal for improvement or the key performance index. I'm not sure in Vietnam what is the KPI for trigger the review of case or your KPI to improve. In my hospital, I have the problem that I set the goal door to ED exits in a severe traumatic brain injury within 60 minutes. But the nearby hospital of my hospital, they set the time different from our hospital, so we can benchmark among the hospital. So you may set the KPI the same KPI in another hospital to benchmark, and this is my hospital trauma audit form. When we analyze the form, we can't audit all of the case. This is because you may have the many trauma case that have the pitfall. So we use some trigger, just like the Dr. Satha said. In Thailand, we use the 3 score and pick up only the trauma case that did and have the probability of survival more than 75%. If this patient have probability of survival more than 75%, they should not die by this injury. So we pick up this case and use this hospital trauma audit form. We analyze the process pre-hospital care, emergency department care, operation room, trauma critical care unit, ICU, and inpatient ward, and separate the cause of death is the delayed diagnosis, error in diagnosis, error in treatment, error in technique, system inadequate, and complication for death. So, and after the trauma surgeon review this case, they will invite the any department that involve this case, just like if this case error in system inadequate about the pre-hospital care, so they the trauma team invites the emergency department and pre-hospital care to join the trauma audit, show only case, and discuss what is the problem and how to improve it. After that, collect the data and follow in the next month, the death rate is lower or increased. Maybe I use this technique and this method to improve my trauma care system. Okay, this is my suggestion for trauma quality assurance.
Thank you. Dr. Sabaraya, would you like to speak a little bit about your thoughts related to trauma registry research in Vietnam?
Thank you. We all know that having a trauma registry is an essential part of having a good trauma system, because the trauma registry, you collect data right from the pre-hospital care until the time the patient gets discharged from the hospital, and or even up to follow-up. So getting the data throughout the whole the spectrum. But having a trauma registry can be labor intensive also. So if you want to start looking at start your trauma registry in your country, look into the data that what you want to do. Maybe look into the data that you want to collect that's important for you to look at it now. The education, as all mentioned by previous speaker, the quality assurance, the protocol. Make it simple to start off with. Then as you move around, as you move, then you can start adding things to your trauma registry, because people are more familiar with. When we started our PATOS registry, if I'm not mistaken, we make it quite simple. We have more like epidemiology things that is easily captured when the patient comes to your ED. As we progress in for the next our next revision, for the revision, we added other things to the registry. So you can also do such things. Gather together and find what is it you want from the registry and develop from there. And of course, with the data from registry, do your research and look at the quality indicators that you have set. Because just collecting a data is just collecting the fruits without eating the fruits, right? So do the research on it, look into what you want, right? And I wish you all the best of luck to start your own trauma registry. And we hope that the Vietnam Trauma Registry will link to the PATOS registry, right? So that we can still have a good Pan-Asian outcome study. Thank you.
Okay, thank you very much. And from four experts, we get some good idea about the education training, protocol development, and then quality assurance and the physical registry. So any comment from Dr. Hong? Okay.
As I think to improve clinical outcome of severe trauma, measuring quality of trauma care system is very important, and database would be the first step. So as I think PATOS could be a good baseline to start to make optimal database in Vietnam. So there are many standard variables and there are many standard data collection system, but as I think some optimization of this kind of manner is important, because in South Korea, we selected EMS-based registry for severe trauma because in South Korea, our Korean citizens overuse ambulances because they are not emergency condition. They call EMS and they always use ambulance. So as we think, if we capture the EMS used cases, every severe trauma will be enrolled in our system. So such kind of finding best way for Vietnam trauma care system is important. I don't have a deep understanding of Vietnam trauma care system, but if there is some difference in usage of ambulances or you have many different EMS systems, you should find what is the best way to collect all severe trauma cases for Vietnamese trauma care system, as I think.
Thank you. And comment from Brian. You are living in Ho Chi Minh City for a long time, short time. Give us some comment for what is the best approach to develop the trauma care system in Ho Chi Minh City and Vietnam.
I think you've heard it already today, focusing on the basics, from bystander care to pre-hospital care, the change that's occurring with education around EMT and paramedic, that will take probably 1 decade, from today to about 10 years to develop that system. But I believe there's been a lot of thought put into how to develop that curriculum and develop a professional degree of paramedicine. I think it's different than the US, and I think it's better. So it will take time, but you'll have the right building blocks. Same with hospital-based trauma care. As you've heard today, there's not trauma surgery here as a subspecialty. This was not any different than in Thailand just 20, 25 years ago. How did it develop there? Same way. There was recognition that you had many subspecialists that took care of the patient, but no one person in charge. And over time, that position developed. And I think it will be the same here. So focusing on the basics and integrating and linking pre-hospital care with hospital care, the team approach often helps save the patient. The care they get obviously is very important, but the coordinated team approach decreases delay and allows the patient to get within that golden hour. A lot of time, we know patients sitting at one hospital that needs to be in another hospital. If that is coordinated, patients will have better outcomes. So it really is a combination of education, but also implementation and organization. So you'll see the system evolve, I think, as the standards change over time.
Okay, so any people, if you are a doctor is working in any place, could you raise your hand, doctor? Only one person? Okay, raise your hand. Yeah, okay. Down, and then nurse? Oh, no nurse. Oh, thank you. And any, yeah, thank you. And public official, public health officials? No. And actually, this is a discussion for how can we develop, how can we build up trauma care system. The topics today is about how can we build up trauma care system in Ho Chi Minh City and each province and the country. It's a kind of designing and progress of the program. So I think one of the important thing is medical directors should be developed. Medical director is one of the director. Like we can make a drama director. We can make a film director. Like this, the system director should be developed in this country. So who is a medical doctor? Because they know the knowledge and skill about the trauma. And then they have been experienced many other countries. So medical directors should be developed. They can make a program, designing, talking, collaboration between civilian and military. The hospital and then 115. And then community providers and first responders and then hospital doctors. So the protocol development, education training, and quality assurance, and then research is all things should be led and then designed by the medical director. So I think the Dr. Lei is trying to develop the EMS system here, and then hopefully you can make a good team from among the participating doctors and then nurses and then paramedics and the officials to develop this medical director program, because they can make an idea together and then they can make the next progress. So today we have a lot of discussions. Dr. Le, could you give a final comment? How can you develop the building of the trauma care system here?
Thank you, Professor Singh, for in my conclusion. I already talked my opinion. Up to now, we have so many trains of like the brand for the last 10 years. We have so many trains. Yeah, in the government thing, in your practice. Yeah, but still now we have to face the challenges, but we try. In the first step, we need to do how to do it. If we wait the 115 or the supply more the full field service for the pre-hospital care cannot. Yeah. So up to now, emergency, we need to combination. And EM doctor, the responsibility for the pre-hospital care too. And then we go together, we go far. I think with the firstly, EM department at hospital need to go to with the pre-hospital care 115. And we need to say to ourselves. We need to say to ourselves before. So we need to say, we will to say the patient with it. I think so. Thank you.
Okay, thank you, Maris. Finishing this session. Okay, thank you. Go to your seat, please.
Seoul National University Hospital. This presentation is the last presentation of today's symposium. So let's go. Okay. PATOS has been collecting information on trauma patients since 2015. A total of 3 sets of data has been distributed from phase 1 to 3. And in December 2023, about 200,000 cases collected over 7 years were released. This data is a crucial essential resource for research and policymaking regarding trauma care in Asian countries. So the data collected by country shows that Korea has the highest number of cases, followed by Vietnam. The Vietnam PATOS team is collecting trauma data to improve the trauma care system. So through research utilizing this. Okay. Okay. So research utilizing this PATOS data, the trauma care system in Vietnam can be further developed. So, researchers interested in conducting research using the released PATOS data can fill out this study proposal request form and send it via email to PATOS CRN. When submitting proposals, please clearly outline the study hypothesis and its significance, as well as specify the study population, exposure, and outcome variables based on the hypothesis. The 5 co-chairs of the PATHOS Research Committee will evaluate your study proposals on 7 criteria: introduction, hypothesis, methods, statistical method, and its significance. If accepted, your proposal will be assigned to one of the 5 research committees. A total of 96 study proposals have been approved by PATHOS CRN, out of which 21 have been published. About 2 abstracts are submitted and under review each month, and recently there has been a significant increase in study proposals submitted from Thailand. Here is the list of the 21 published papers using PATHOS data. I will introduce the data and the papers, published papers. This paper was published in Pre-Hospital Emergency Care by the PATHOS CRN concerning the PATHOS study methodology. Next one is focused on the EMS and EMS system and trauma care system of the PATHOS countries. This paper also focused on the trauma care system of PATHOS countries using different study methods. These papers focused on the epidemiology of trauma patient in PATHOS, with particular interest in age of the patient. Next one focused on the time of injury, while other one focused on alcohol intake before injury. Next paper, this paper is focused on the pre-hospital treatment, fluid resuscitation, cervical spine immobilization, and their association with the survival outcomes. These papers are interested in the pre-hospital time interval and its association with the survival outcomes. The first one is interested in the GCS score of a trauma patient, and the next one is developing prediction model using machine learning method. These papers focused on the field triage and the vital sign for predicting mortality of trauma patient. These papers address the shock index and its association with the survival outcomes. These papers are also focused in the shock index. The following paper is interested in the time to definite care and its association with survival outcomes. So you can make your own research ideas based on these published articles. So in February 2024, PATHOS CRN revised its study protocol. Firstly, since 2023, PATHOS data has been accessible to researchers affiliated with the participating institute. Researchers approved by the national PI of PATHOS can submit study proposals. Secondly, regarding the co-authors, it's required to include Dr. Sang Do-shin, the chair of pathos, and one of the chair of the 5 research committees to which the study proposal belongs. Other co-author can be chosen by the first author and corresponding author. Thirdly, concerning the study timeline, the approved proposal must be completed and published within 2 years from the date of approval. And if these regulations are violated, penalty will be applied if the approved approved study proposal is not published within 2 years. Study topic will be withdrawn and the topic will be released to other interested members. Additionally, if the paper does not comply with the regulation for co-authorship, the first author and the corresponding will be restricted from using the data for the next 6 months. Finally, let me introduce the Young Investigator Group currently operating within pathos CRM. Presently, we have a total of 17 members from countries including Korea, Vietnam, Thailand, Malaysia, and Taiwan. If you are interested in joining the Young Investigator Group, please contact pathos CRM. We hold separate research meetings. Now, here's the list of abstracts under discussion in the Young Investigator Group. We are committed to supporting young researchers who are interested in studying trauma care system. We believe that this initiative will active trauma research and contribute to other advancement of trauma care system in Asia.
Thank you, Dr. Yong Sunro, with your research update and summary. Now, welcome on stage Dr. Sang Do-shin with your wrap-up and summary of our symposium today.
Okay, thank you. Thank you very much, everybody. It's a long day, long journey. It is first time the pathos meeting in Ho Chi Minh City, and then everybody has it's been interested in this meeting, and then we had a lot of discussion today. So first, we have learned how much we have trauma burden in the world and in this country. And the second session, we had the EMS trauma care, EMS and hospital protocol, and education and training, and then quality assurance, which is the 3 components of the system development: the protocol, education training, and then quality assurance. And in the afternoon, after lunch, we have some international showcase. We had a great time from hearing from the Singapore, Thailand, Malaysia, and Korea, and also Vietnam. So then finally, we have had a good time for how can we build up the trauma care system in this country. And the advisors gave us some good comments, which is the priority, which is the importance of your activities to build up the trauma care system in this country. So finally, we get some information about how can use the pathos data and how many papers were published using the data. So I would like to summarize today's meeting. So it's a first step to start to develop the system and the research network here. Already the Thong Nhat Hospital has contributed a lot of the data to the PETOS Clinical Research Network. I hope all of you can work together and to make a new network and to develop the research network and then the group of the medical directors who will be working together for lead the trauma care system development. Then finally, I'd like to give us a good thanks to the PETOS CRN to develop this meeting, and then Thongnat Hospital and hosting body, all of your colleagues, Dr. Lei and colleagues. Thank you very much. And then we'll have another meeting in this June in the Taipei, as I told you in the previous session. The meeting will be hosted in June 21st in Taipei, which is during the ICEM, International Conference on Emergency Medicine. And then I'm not sure the exact date. The Thailand will be continues to host the third Thailand PETOS meeting in this autumn or early winter. Not decide whether it's maybe Bangkok. And then the next March or April, we still expecting the second PETOS meeting here to celebrate what we did for the last 1 year, what we achieved during the 1 year. So thank you very much, all of you, to be here. And I hope all today meeting you can get a good idea. And then tomorrow we'll continue to get the workshop for getting the more in details of the skill to provide a good team trauma care. It's an epic TBI course here. Thank you very much.
Thanks, Professor Shang Do-shin. And now is the closing remark of Dr. Lê Bảo Huy.
Good afternoon, and thanks for your honor you to stay here. We'll stay here. And up to now, we have in the hall so many colleagues give each us. Yeah. And once again, on behalf of the PETOS Vietnam and Thongnat Hospital, I would like to give many thanks for the expert from the other country to give so many interesting lecture and sharing their experience about the build up the trauma care system and how to build up in Vietnam. As the professor saying, I think we have today we have the strong to develop network, and I hope to see you in the next in the next year. Yeah, and we shall how to do it. We already. And once again, hope to you all of you to see tomorrow if you drive in the two day. And for my business friend, my for a speaker, I have you have much more time to take it in Ho Chi Minh City. Thank you. Xin các anh chị có đăng ký 2 ngày thì chúng ta ở lại để chúng ta trao đổi một chút ha. Dạ. Và các bạn khác chuẩn bị để các thầy cô sẽ có một cái phần rehearsal cho ngày mai và chuẩn bị cho cái phần dinner. Xin mời các anh chị hỗ trợ giúp ạ.